Good morning or good evening to everyone, depending on your geographical location. Thank you for joining me today. I'm excited to share with you a fascinating evolution in our understanding of oral cancer, specifically the remarkable role of saliva. Once merely seen as a simple lubricant, saliva is now recognized as a key player in our body's biological processes. What's truly inspiring is that saliva can reveal molecular changes happening in our bodies, often before we even notice any symptoms. It mirrors shifts in the oral microbiome, signals underlying inflammatory pathways, and can even reveal cancer-related biomarkers, acting as an early warning system. This means saliva has emerged as an invaluable, non-invasive diagnostic tool for the early detection, monitoring, and prognosis of oral cancer. This breakthrough not only enhances patient care, but also opens new avenues for dental practice, allowing us to act sooner and more effectively.
Let's embrace this change and leverage the potential of saliva in our fight against oral cancer. This concept of saliva omics is not new. As early as the mid-20th century, Dr. Captain Kirk Horman, a dentist from the U.S. Navy, observed elevated acid phosphatase levels in the saliva of patients with prostate cancer. This was a groundbreaking discovery, indicating that saliva could reflect systemic disease. Today, this early insight has evolved into the field of salivary liquid biopsy, where saliva contains DNA, RNA, proteins, and microbial signatures that correlate with malignancy. What was once a curiosity has become a rapidly expanding area of cancer diagnostics. Dr. Captain Kirk Horman, a U.S. Navy dentist, made a groundbreaking observation in the mid-20th century when he detected elevated acid phosphatase levels in the saliva of patients with prostate cancer. This pivotal finding suggested that saliva could reflect systemic diseases. Fast forward to today, and this initial insight has given rise to the promising field of salivary liquid biopsy.
Researchers have since uncovered that saliva is rich in DNA, RNA, proteins, and microbial signatures that can indicate the presence of malignancy. What began as a simple curiosity has now blossomed into a vital and rapidly advancing area of cancer diagnostics, revolutionizing how we detect and understand disease. Allow me to introduce myself briefly. I graduated from the Government Dental College and Hospital in Mumbai and completed my training in oral and maxillofacial surgery at the same institute. With 40 years of experience as an oral and maxillofacial surgeon, I have held various positions, including professor, research director, and chairman of the Central Board of Accreditation of Healthcare Institutes at Chakra Hospital in Saudi Arabia. Additionally, I have served as a healthcare management consultant. I am the director of Happy Sapiens Dental in Houston, Texas, USA, and a member of the advisory board for Warka's Research and Innovations Ptd Limited.
In India, I am also a founding member of the Oral Premalignant Disorders and Oral Cancer Education and Research Foundation. I am recognized as a consultant in oral and maxillofacial surgery and an academician, researcher, educator, and author. My current interests are twofold: exploring the role of the oral microbiome in carcinogenesis and utilizing salivary biomarkers to achieve earlier disease detection.
Oral cancer does not develop suddenly. A lengthy precancerous phase usually precedes the tumor. Risk factors such as tobacco, areca nut, alcohol, and HPV cause chronic mucosal injury. This injury can lead to oral potentially malignant disorders, including leukoplakia, erythroplakia, oral lichen planus, and oral submucosis fibrosis. With ongoing exposure, genetic and epigenetic damage accumulates, gradually progressing from epithelial dysplasia to carcinoma. The key point is this: dentists are involved at every stage, identifying risk, detecting early signs, and making referrals. The role of dentists lies in the every 4 stages of oral cancer development. 1. Prevention of the development of OPMD in patients with tobacco and areca nut-related pathological oral habits, alcohol consumption, and HPV-related habits. 2. Early diagnosis of OPMD and OED using various oral screening and diagnostic techniques. 3.
timely treatment of OPMD and OED to prevent progression of OPMD and OED into OSCC. 4. Referral to an appropriate specialist for further management. Such deep involvement of dental professionals in the early diagnosis of OPMD and oral cancer makes it necessary for them to know about oral microbiota and biomarkers at every step of OPMD and oral cancer prevention and development.
Why is there a delay in the diagnosis of OPMD and oral cancer by dental professionals? Practical challenges. What are the barriers to the early detection of OPMD and oral cancer? A. Challenges faced by general dental practitioners. 1. Limited access to diagnostic tools. 2. Financial barriers. 3. Scope of practice. 4. Patient expectations. 5. Fear of litigation. B. Patient factors. 1. Access to healthcare. 2. Reluctance to seek oral examination by a healthcare worker. Denial of screening examination of suspicious lesions. Practitioner factors. Absence of knowledge of oral premalignant disorders. No high suspicious index. No proper instrumentation available. Absence of knowledge of how to use instruments and interpret the results. Although our responsibilities are significant, we face practical challenges, including restricted access to advanced diagnostic tools, financial limitations, patient hesitancy, and concerns regarding overdiagnosis or potential litigation. Patients often seek reassurance rather than investigation, and as clinicians, we sometimes hesitate when lesions are subtle or ambiguous. These real-world factors contribute to the persistently low rates of early oral cancer detection, despite the ease of visual examination of the oral cavity. If you want to be an expert in the early diagnosis of OPMD and oral cancer, you need to develop 4 qualities in your dental practice. 1. Power of observation. 2. High suspicious index. 3. Improving your knowledge about OPMD and oral cancer. And 4. Improving the clinical acumen regarding saliva omics and biopsy techniques. By meticulously developing these 4 qualities, power of observation, high suspicious index, enhanced knowledge, and clinical acumen, dental practitioners can significantly improve their expertise in the early diagnosis of OPMD and oral cancer. This multifaceted approach not only refines clinical skills, but also elevates patient care, fostering an environment where early detection and intervention can thrive. Our predictive models are inadequate. Histological grading of dysplasia is subjective and inconsistent, and many cancers arise from lesions without clear signs of dysplasia. In summary, morphology alone cannot reliably forecast malignant transformation. We require molecular tools capable of detecting disease before structural changes occur. Systematic reviews confirm a lack of high-quality evidence regarding the malignant transformation of oral potentially malignant disorders, OPMDs, due to inconsistent diagnostic criteria, low methodological quality of primary studies, and subjective histopathological reporting. Subjectivity is a significant issue in histological grading of epithelial dysplasia, as the diagnosis relies on interpreting a continuum of cellular and architectural changes, resulting in poor reproducibility and a lack of consensus among observers. This subjectivity arises from the arbitrary nature of dividing a continuous process into distinct grades, even with established systems like the WHO classification, and can lead to significant inter- and intra-observer variability. To address this, some have proposed simplified binary systems, low risk versus high risk, to improve consistency and prognostic value. The lack of reliable predictive markers is a significant challenge in medicine, particularly in cancer treatment, due to factors such as tumor heterogeneity, assay variability, and false positive-negative results. This means that while some markers exist, they often aren't accurate enough for widespread use, leading to inconsistent treatment decisions and the need for more reliable and frequently more expensive methods to identify the best course of action for an individual patient. While the consensus is that a higher grade of dysplasia increases the risk of malignant transformation, the relationship is not perfectly linear or entirely predictable for individual lesions. This uncertainty stems from diagnostic subjectivity, variations in study results, and other contributing risk factors.
Why saliva
and microbiome. Saliva plays a crucial role in this context. It is easy to collect, non-invasive, repeatable, and cost-effective. Rich in cells, extracellular vesicles, microbial DNA, and soluble biomarkers, saliva is an ideal medium for studying the oral microbiome and molecular changes linked to cancer. Advantages of saliva as a diagnostic tool. 1. Non-invasive, economical. 2. Safer to administer than serum sampling, no needles. 3. Real-time diagnostic values. 4. No one would like to have trained medical workers. 5. Multiple samples may be obtained. 6. Collection and screening may be done at home. 7. Minimizes the risks of cross-contamination. 8. Saliva doesn't clot and might be manipulated more simply than blood. 9. Requires less manipulation throughout diagnostic procedures, compared to serum. 10. More economical sampling, shipping, and storage, compared to serum. 11. Commercial availability of screening assays.
Why saliva and microbiome? Oral microbiota contributes to oral cancer through various mechanisms, including the induction of chronic inflammation, alterations in cell proliferation and apoptosis, the production of carcinogens such as acetaldehyde, and disruption of immune responses. Dysbiosis, an imbalance in the microbial community, is frequently observed in precancerous and cancerous lesions. Certain bacteria, such as Porphyromonas gingivalis and Fusobacterium nucleatum, have been strongly linked to tumor initiation and progression.
Poor oral hygiene and oral microbiome. The relationship between oral bacteria and squamous cell carcinoma, OSCC, has not been fully characterized. A study by Ling Zhang et al. Found that bacterial richness and diversity were significantly higher at tumor sites compared to control tissues. The analysis showed that cancerous tissues were enriched with 6 bacterial families: Prevotellinaceae, Fusobacteriaceae, Fladolacteriaceae, Lachnospiraceae, Peptostreptococcaceae, and Campylobacteriaceae.
Additionally, 13 genera, including Fusobacterium, Alloprevotella, and Porphyromonas, were notably present. At the species level, there was a marked increase in bacteria such as Fusobacterium nucleatum, Prevotella intermedia, aggregate Actobacter segnis, Capnocytophaga ledbetteri, and Peptostreptococcus stomatis, among others, suggesting a possible link to OSCC development. Functional predictions indicated an increase in genes related to bacterial chemotaxis, flagellar assembly, and lipopolysaccharide (LPS) biosynthesis in the OSCC group. These processes are associated with various pathological mechanisms. Overall, the oral bacterial profiles showed significant differences between cancerous and normal tissues in OSCC patients, implying these microbial populations could serve as diagnostic markers and potential therapeutic targets.
The role of oral microbiota. Poor oral hygiene allows bacterial buildup, leading to a microbial imbalance known as dysbiosis. This shift in microbes induces a chronic inflammatory response in the gums and surrounding tissues, characteristic of periodontal disease. Such localized inflammation can have systemic repercussions, as inflammatory mediators and bacteria may enter the bloodstream, exacerbating other health conditions. Dysbiosis. Inadequate oral hygiene disrupts the natural balance of the oral microbiome, causing harmful bacteria to dominate beneficial ones. Immune response. The immune system's reaction to the excess harmful bacteria significantly contributes to tissue damage. Inflammatory mediators. The immune response releases pro-inflammatory cytokines and enzymes that, while fighting infection, also degrade the connective tissues and supporting bone. Systemic effects of oral inflammation. Chronic mouth inflammation is interconnected with systemic health issues. Bacteria and inflammatory mediators can enter the bloodstream and affect other organs. This persistent, low-grade systemic inflammation is associated with cardiovascular disease, diabetes, and neurodegenerative conditions.
Oral bacteria associated with cancer, such as Fusobacterium nucleatum and Porphyromonas gingivalis, contribute to tumor development and progression through multiple molecular mechanisms, inducing chronic inflammation, stimulating cell proliferation and invasion, suppressing the immune response, and producing carcinogenic compounds. It is crucial to understand the role of oral microbiota in oral carcinogenesis. Key molecular pathways: induction of chronic inflammation. These bacteria activate host signaling pathways, including NF-kappa B and STAT3, via molecules like lipopolysaccharides, LPS, and flagella. This activation results in sustained secretion of pro-inflammatory cytokines, e.g. IL-6, IL-8, TNF-alpha, creating an inflammatory microenvironment that promotes tumor growth and cell survival. Regulation of cell cycle and apoptosis. P.
Gingivalis inhibits apoptosis in epithelial cells by overstimulating JAK1 STAT3 and PI3K AKT pathways, allowing damaged cells to persist and accumulate mutations. It also disrupts p53 tumor suppressor function. F. nucleatum hampers DNA repair processes and the p53 pathway, leading to DNA damage and genomic instability. Promotion of proliferation and invasion. F. nucleatum uses its Fad-A adhesin to bind E-cadherin on epithelial cells, disturbing cell junctions and activating beta-catenin signaling, which enhances proliferation and invasion. P. gingivalis secretes gingerpains, proteases that degrade extracellular matrix components and activate MMPs, especially MMP9, facilitating tumor invasion and metastasis. It also induces epithelial to mesenchymal transition, EMT, increasing migratory and invasive capacities. Immune evasion. F.
Nucleatum interacts with immune inhibitory receptors like TIGIT, T-cell immunoreceptor with Ig and ITIM domains, and CAACAM1, carcinoembryonic antigen-related cell adhesion molecule 1, on immune cells, suppressing their anti-tumor activity. It also recruits immunosuppressive cells, such as MDSCs, to the tumor site. P. gingivalis upregulates B7H1, leading to T-cell inactivation and apoptosis. Carcinogen production. Some oral bacteria, including Streptococcus and Neisseria species, metabolize ethanol into acetaldehyde, a group 1 carcinogen that damages DNA and promotes cell proliferation. In summary, these bacteria foster a tumor-friendly environment by manipulating host cell functions and immune defenses, supporting the survival and spread of cancerous cells. Candida albicans can promote the development and progression of oral cancer by creating a pro-inflammatory environment and generating carcinogenic byproducts, but the exact role and causality are still under investigation. Mechanisms include chronic inflammation, production of metabolites like acetaldehyde, and secretion of proteins that damage DNA, promote invasion, and suppress the immune system. Mechanisms of action. Chronic inflammation. Chronic candida infections induce inflammation, oxidative stress, and immune dysregulation, which can lead to DNA damage and genomic instability. Carcinogen production. C. Albicans metabolizes ethanol to acetaldehyde, a known carcinogen that can cause DNA damage and interfere with DNA repair. Protein and metabolite secretion. Secreted proteins like aspartyl proteases, SAPs, and phospholipases promote epithelial invasion, immune evasion, and inflammation. Acetaldehyde production, along with the formation of nitrosamines, a different carcinogen, by bacteria in a dysbiotic environment, contributes to cancer development. Immune system modulation. C.
Albicans can create an immunosuppressive environment by attracting macrophages that promote tumor growth and by suppressing T cells, hindering the body's ability to fight cancer. Epithelial damage. Candida can damage the mucosal epithelium, which over time can lead to pre-malignant lesions that may progress to cancer. Clinical correlation and research. There is a strong association between chronic candida infections, particularly in oral potentially malignant disorders, and oral squamous cell carcinoma, OSCC. Studies have observed higher fungal carriage in oral cancer patients and documented malignant transformation in some cases of chronic hyperplastic candidiasis. While evidence suggests a promoting role, research is ongoing to determine if C. albicans can directly cause cancer, or if its role is mainly to promote the progression of existing cancer.
Some experts advise close monitoring of recalcitrant candida lesions and consider their removal, as they may be linked to cancer development.
A correlation between oral microbiota and oral cancer is plausible. Sami et al. Examined the relationship between the oral microbiome and OSCC, highlighting the ongoing debate about causality. They proposed two hypotheses. One suggests that specific bacteria or groups of bacteria directly initiate carcinogenesis, altering the microbiome to create an oncogenic environment that damages healthy epithelial cells, bacteria before tumor, while the other considers bacteria as opportunistic occupants within the OSCC tumor environment that may influence tumor progression, bacteria after tumor. To clarify this link, it is crucial to investigate the molecular mechanisms connecting oral microbiota, the host immune response, and the signaling pathways involved in oral carcinogenesis. Numerous mechanisms enable microorganisms to interact with the host immune system.
The oral microbiome may contribute to carcinogenesis through chronic inflammation, promoting cell proliferation, invasion, angiogenesis, inhibiting apoptosis, and producing carcinogenic substances. Several anaerobic bacterial species have been implicated in oral cancer development, notably from the phyla Bacteroidetes and Fusobacteria, with Porphyromonas and Fusobacterium being the most studied. Other species found in higher concentrations in oral cancer patients include Prevotella, Peptostreptococcus, Veillonella, Haemophilus, Rothia, and Streptococcus.
Risk reduction. Slide 15, 1 minute. A brief clinical reminder. Ceasing tobacco use reduces the risk of oral cancer by approximately 50% within 5 years and nearly returns to baseline after 10 to 15 years. This information is highly impactful for patient counseling.
The therapeutic implications of the microbiome encompass utilizing it to treat diseases through methods such as fecal microbiota transplants, probiotics, and dietary modifications aimed at restoring a healthy microbial balance. Additionally, the microbiome plays a crucial role in influencing individual responses to conventional medications, affecting their effectiveness and side effects, which has significant implications for personalized medicine and drug development. Therapeutic approaches include microbiome-based treatments, developing strategies to directly modify the microbiome for disease treatment, fecal microbiota transplantation, FMT, transferring fecal matter from a healthy donor to a patient to reestablish a balanced gut microbiome, probiotics and prebiotics, using beneficial live bacteria or compounds that promote their growth to rebalance the microbial community, phage therapy, employing viruses that specifically target and eliminate harmful bacteria, enhancing immunotherapy. The microbiome can modulate immune responses to improve treatment outcomes, especially in cancer immunotherapy. Certain bacteria have been shown to boost the efficacy of immune checkpoint inhibitors. The composition of bacteria within the tumor microenvironment can also influence immune responses to therapy. Drug development. Understanding the microbiome's role aids in creating new drugs and therapies derived from microbes, known as pharmabiotics. Implications for existing therapies include drug response and side effects. The microbiome significantly affects how drugs are metabolized, impacting their efficacy and toxicity. Microbes can convert drugs into different compounds, altering their activity. Personalization of treatment. Analyzing an individual's microbiome may help predict their response to medications and enable tailored treatments, advancing personalized or precision medicine. Disease prevention. Dysbiosis, or microbiome imbalance, is linked to various conditions such as cancer, diabetes, and obesity, emphasizing the importance of maintaining a healthy microbiome to prevent these diseases.
1. Role of oral bacteria in cancer pathogenesis. Oral bacteria significantly contribute to oral cancer pathogenesis. Species like P. gingivalis and F. nucleatum drive inflammation, cell proliferation, and metastasis. 2. Dysbiosis as diagnostic and prognostic biomarker. Dysbiosis observed in OSCCC patients highlight microbial profiles as potential biomarkers. These profiles could aid in the diagnosis and prognostic of oral cancer. 3. Future research directions. Large-scale, multi-omic studies are needed to define microbial signatures. Research should focus on elucidating the mechanisms by which microbes influence oral cancer. 4. Therapeutic strategies for personalized cancer management. Probiotics, prebiotics, and engineered bacteria show promise as therapeutic strategies. These approaches could enable personalized management of oral cancer. 5. Advancing understanding of microbial host interactions. Improved knowledge of microbial host interactions is crucial. This understanding will lead to the development of novel diagnostics and targeted treatments for patients with oral cancer.
Salivary biomarkers are utilized in oral cancer detection because saliva is a non-invasive, cost-effective medium that reflects local and distant physiological changes, and cancer cells are shed directly into it. Identified biomarkers include proteins such as Saliva 21-1 and BFGF, DNA, and RNA, including microRNAs, which can be detected even before visible symptoms appear. This provides a simpler, faster screening tool than traditional methods and can be used for early detection, monitoring treatment response, and assessing recurrence.
Let us visualize a routine clinical scenario in your clinic. A patient comes into your clinic to know if he has any signs of oral premalignant disorder or oral cancer in his mouth. Patient's history reveals that he has a habit of chewing areca nut and tobacco and also drinks alcohol. You carry out a comprehensive clinical examination, even use visual aids, and only find that one lower molar is missing in the patient's mouth. You say, "No, you do not have any signs of oral premalignant disorder or oral cancer, and it seems you are not likely to develop oral cancer in your mouth in future." Are you right or wrong? A deep silence follows. Yet in that silence, a deeper understanding emerges within you. While the surface looks clear, the reality is layered and complex. You recall the prevalence of insidious changes that often go undetected, especially in patients like him.
Tobacco and areca nut usage, coupled with alcohol, forge a trifecta of risk that cannot simply be dismissed because the visible signs are absent today. However, you continue, leaning forward slightly. It's crucial we discuss your habits. Even in the absence of current signs, your history puts you at greater risk for developing oral cancer in the future. You watch as the patient's brows furrow, understanding dawning, a subtle shift from the initial relief to a realization of reality. Routine examinations are vital, and I recommend we schedule follow-ups every 6 months to monitor for any changes.
We can also explore options for reducing and eventually quitting these habits that pose serious threats to your health. You offer reassurance with a gentle smile, making it clear that while today may be a victory, the battle is ongoing. A sense of fulfillment washes over you, not just for the absence of disease today, but for the knowledge imparted, the conversation started, and the potential futures altered. "Thank you, doctor," he says, the tremor in his voice replaced by resolve. You nod, understanding that health is not merely the absence of disease, it is also the presence of knowledge and proactive choices. As he leaves, a wave of hope mingles with the what-ifs in your mind. In this intricate dance between reassurance and caution, you remind yourself that your role extends beyond mere diagnosis. You are an educator, a guide, and a partner toward ongoing health. And perhaps that balance is the true art of what you do, one that fosters confidence even amidst the complexity of risk. Think of oral microbiota and salivary biomarkers at this stage. Limits of conventional oral examination. Challenges with visual examinations include subjectivity and variability, as well as patient-related factors like cooperation, fatigue, and difficulty communicating, particularly in children or individuals with cognitive impairments. Environmental and test-specific issues also play a role,
including inconsistent lighting, equipment limitations, and unclear instructions, which can negatively affect accuracy.
General limitations of conventional oral examinations. Subjectivity. Interpretation of visual findings varies and depends on the clinician's training, knowledge, and experience. Difficulty in differentiation. Visual inspection alone cannot reliably identify lesions as benign or malignant, as many mucosal abnormalities are benign. False negatives. Dysplasia and early cancers may occur in mucosa that appears normal during standard visual exams, risking misdiagnoses. Need for biopsy. Regardless of visual findings, a definitive diagnosis requires biopsy and histopathological analysis, which remains the gold standard. Lack of standardization. There is inconsistency in methodology and interpretation criteria across studies and clinical settings. Conventional visual examination. Cannot distinguish high-risk from low-risk lesions. Limited by the human eye, especially with moist or shiny mucosa. Prone to false positives and negatives, depending on the population.
Visual aids, including conventional visual examinations and adjunctive light-based detection systems, have significant limitations in oral cancer diagnosis, primarily due to their subjective interpretation, variable accuracy, and inability to reliably differentiate between benign and malignant lesions. Subjectivity and operator dependence. Subjective interpretation. Conventional oral examination, or COE, and even advanced visual aids rely heavily on the clinician's subjective interpretation, which can vary greatly depending on their experience and expertise. Inter-observer variability. The interpretation of visual changes, such as the degree of fluorescence loss or staining intensity, can differ between practitioners, leading to inconsistent diagnoses.
Inability to differentiate lesions. False positives. Many benign, inflammatory, traumatic, or pigmented lesions exhibit similar visual changes, either loss of autofluorescence or positive staining, as precancerous or cancerous lesions, leading to high false positive rates. This can cause unnecessary patient anxiety, additional tests, and costly, invasive biopsies. False negatives. Visual aids can miss certain dysplastic or early-stage cancerous lesions, particularly those that are small, located in hard-to-see areas, or have a thick keratinized surface that prevents proper light penetration or staining. This can provide a false sense of security and delay proper diagnosis and treatment. Overlap in appearance. Benign lesions often mimic oral malignancies, making visual discrimination difficult even for experienced clinicians.
Technical and practical constraints. Occult lesions. Dysplasia or early squamous cell carcinoma, OSCC, can occur within mucosa that appears clinically normal under conventional white light inspection, making them difficult to detect without a biopsy. Lack of standardization. There is a lack of uniformity in the methodology and diagnostic criteria for using some adjunctive visual techniques, contributing to the varied results reported in studies. Environmental needs. Some aids, like certain light-based detection systems, require specific conditions such as a dark environment for optimal use, which may not always be practical in a standard clinical setting. Insufficient evidence for mass screening. While some studies show benefits in high-risk populations, there is insufficient evidence to support the use of most adjunctive visual aids as primary screening tools in general low-risk populations.
Ultimately, these tools serve best as adjuncts to an oral examination conducted by experienced clinicians, aiding in identifying areas for biopsy, rather than functioning as standalone diagnostic methods.
Biomarkers. Cancer cells shed molecules into saliva at early disease stages. These include proteins, DNA, RNA, and microRNAs. Such changes happen before lesions are clinically apparent.
Therefore, salivary biomarkers enable the detection of biological changes before physical symptoms appear. The progression of epidermal changes from normal epithelium to invasive squamous cell carcinoma, SCC, highlights the significance of barrier gene loss and inflammation in this process. Normal epithelium consists of distinct layers, basal, spinous, granular, and cornified, forming a functional barrier.
An initial genetic insult results in the loss of key barrier genes, leading to barrier dysfunction. This defect fosters inflammation in the stromal cells, which subsequently drives hyperplasia and dysplasia during premalignant stages. The condition can advance to carcinoma in situ and eventually to invasive SCC, where malignant cells breach the basement membrane. Biomarkers linked to oral mucosal barrier genes primarily pertain to epithelial differentiation, tight junction integrity, and inflammatory pathways.
These markers are frequently examined in the context of oral potentially malignant disorders, OPMD, and oral squamous cell carcinoma, OSCC, characterized by barrier compromise. Loricrin, LOR, a protein essential for forming the cornified envelope, a vital component of the epithelial barrier. While usually absent in non-keratinized mucosa, its expression may signal pathological changes, such as oral submucosous fibrosis. Filament A is a promising biomarker for early detection and progression of OPMDs, with increased expression observed in the early to moderate stages of oral submucosous fibrosis, OSF. It is a cytoskeletal protein that shields the oral mucosa from mechanical stress during initial OSMF phases. Early identification through biomarkers like filament A may enhance prognosis. Remember, chemistry precedes physics. In essence, biomarkers emerge prior to morphological alterations in the oral mucosa.
During oral cancer development, loricrin functions as a protective compensatory barrier in precancerous lesions, but its expression diminishes in oral squamous cell carcinoma, OSCC. This alteration makes it a promising early diagnostic and prognostic marker. Mechanisms of loricrin in oral cancer. Standard function. Loricrin is a major structural protein comprising over 70.
Elevated loricrin expression during early and moderate stages represents a compensatory reaction. Role in malignant transformation, OSCC stage. As the disease advances to OSCC, loricrin expression significantly decreases or is lost entirely. This decline indicates a breakdown of the protective barrier, permitting further genetic damage and tumor progression.
The precise molecular mechanisms behind this downregulation are under investigation, but it is linked to disruptions in normal keratinocyte differentiation pathways. Potential biomarker: variations in loricrin levels, low in normal tissue, higher in precancerous lesions, and reduced in OSCC, highlight its possible role as an early indicator and prognostic marker for malignant transformation in oral lesions. Effect of mutations. In some genetic skin disorders, such as loricrin keratoderma, mutations in the loricrin gene cause abnormal accumulation of mutant loricrin in the nucleus, interfering with normal cell differentiation and delaying apoptosis. Similar mechanisms may be involved in oral lesions, though further research is required. In summary, loricrin initially contributes to cellular protection, but its downregulation correlates with progression to oral cancer. Filament A, FLNA, plays a crucial role in cancer biology, particularly in oral squamous cell carcinoma, OSCC. As a key cytoskeletal protein, it maintains cell shape and supports signaling pathways essential for cell migration and adhesion. Its involvement in cancer is complex, affecting cell motility, proliferation, and apoptosis, thereby contributing to tumor progression. Studying FLNA in OSCC could lead to the identification of biomarkers for early detection and potential therapeutic targets. This presentation will examine FLNA's impact on prognosis and treatment, thereby improving diagnostic and therapeutic approaches for oral cancer.
Dysplasia grading alone does not reliably predict cancer. Some low-grade lesions advance, some high-grade lesions remain unchanged. Molecular profiling offers a more objective way to assess risk. 3 significant issues are associated with the significance of oral epithelial dysplasia in forecasting malignant transformation in OPMD. 1. The diagnosis is fundamentally subjective. 2. Not all lesions showing dysplasia will necessarily become malignant, and some may even regress. 3. Carcinoma can develop in lesions where epithelial dysplasia was not identified in previous biopsies. Markers related to epithelial differentiation, and more recently genomic markers, could serve as promising tools to enhance the prognostic assessment of OPMD. Salivary biomarkers like IL-6, IL-8, TNF-alpha, MMP9, and cyclin D1 show promise for predicting malignant transformation in oral epithelial dysplasia, OED, because their levels often increase with dysplasia severity, indicating higher risk.
Other key markers include EGFR, P16, MDM2, and specific microRNAs, which reflect cellular changes like uncontrolled growth and altered apoptosis, helping to identify high-risk lesions for early intervention. While promising, these need large-scale clinical validation to become standard tools.
The significance of the hallmarks of cancer is that they provide a unifying framework, a biological roadmap to understand the complex traits cancer cells acquire, like unlimited growth, evading death, invasion. This framework helps researchers rationalize cancer's multifaceted nature, identify key biological processes like metabolism, immunity, genome instability that drive cancer, and guide the development of new targeted therapies by highlighting common vulnerabilities across different cancers. These fundamental changes drive cancer, and many appear in saliva. Sustained proliferative signaling, uncontrolled cell growth, evading growth suppressors, disabling cell cycle breaks, e.g. P53 pathway, resisting cell death, apoptosis, cancer cells survive longer, angiogenesis, forming new blood vessels to feed tumors, DNA damage and repair issues, genetic instability, altered metabolism, changing energy use.
Salivary biomarkers, what's found in saliva. Saliva captures these changes through different omics. 1. Genomic biomarkers, DNA/RNA. Mutations/alterations in genes like P53, mitochondrial DNA. Epigenetics, DNA methylation, hypermethylation of HOXA9, NID2. RNA, microRNAs, miR125A, miR200A, miR31A, and long non-coding RNA, HOTAIR. 2. Proteomic biomarkers, proteins. Inflammation, IL-6, IL-8, TNF-alpha. Cell cycle/growth, cyclin D1, CYCD1. Tumor suppressors/inhibitors, MASPIN, decreased. Tissue remodeling, MMP9. General proteins, amylase, lactoferrin, mucins, cystatins. 3. Metabolomic biomarkers, metabolites. Changes in amino acid, polyamine, and energy metabolism. Increased carbonyls. Key biomarkers include altered methylation, HOXA9, NID2, elevated IL-8, TNF-alpha, and decreased MASPIN, offering insights into tumor progression.
Precancer presents our most significant opportunity. While most research concentrates on advanced cancer, early intervention at the molecular precancer stage can substantially lessen the disease burden. Identification of cellular and molecular markers specific to these oral premalignant disorders with the potential for malignant transformation could facilitate early detection and accurate diagnosis, prevent oral squamous cell carcinoma, OSCC, and enable targeted therapy. Saliva is arguably the most promising secretion for the discovery of biomarkers for OSCC and OPMDs, given its ease of collection, non-invasiveness, speed, and cost-effectiveness. Consequently, numerous studies have investigated salivary factors as potential biomarkers for the development and progression of OSCC and OPMDs.
Various biomarkers associated with OPMD development have been documented in the literature. This diagram illustrates the molecular pathways involved in oral potentially malignant disorders, OPMD, specifically oral submucosal fibrosis, leukoplakia, erythroplakia, and oral lichen planus. MDA, 8-OGDG, and LDH characterize oral submucosal fibrosis. Increased levels of inflammatory markers such as TNF-alpha, IL-1 beta, IL-6, and IL-8 characterize leukoplakia. Erythroplakia involves genetic alterations, including P53 mutations and polysomy of chromosomes 7 and 17. Oral lichen planus is associated with cortisol and inflammatory markers, including CRP, reactive oxygen species, ROS, and TNF-alpha.
The main groups of salivary biomarkers that are mainly associated with oral squamous cell carcinoma, OSCC. These biomarkers can be used for non-invasive diagnosis and monitoring of oral cancer. Cytokines: interleukin, IL-1 alpha, IL-1 beta, IL-6, IL-1RA, IL-10, and tumor necrosis factor alpha, TNF-alpha. Growth factors: vascular endothelial growth factor alpha, VEGF-alpha. Matrix metalloproteinases, MMP1, MMP2, MMP3, and MMP9. Acute phase proteins, AAT-alpha, HAP-beta, HPX, C3, TTR, FIB-beta, serotransferrin, and RET-N. Proline-rich proteins, APRP, BPRP, and GPRP.
Salivary biomarkers demonstrate promising, often high, diagnostic accuracy for various conditions such as cancer, periodontitis, and COVID-19. Meta-analyses report overall AUCs around 0.85 for cancer, with specific biomarkers achieving excellent sensitivity and specificity over 90% for oral diseases, especially when using combinations or AI models.
This makes saliva a valuable non-invasive liquid biopsy for early detection and monitoring, though accuracy varies significantly by disease and biomarker. Cancer: meta-analyses indicate moderate to good accuracy, AUC approximately 0.85, for detecting non-oral cancers, with potential for improvement through the use of multiple biomarkers or AI. Factors affecting accuracy: biomarker type. Proteins, DNA, mRNA, microRNAs, and metabolites each provide different insights. Combination models, employing multiple biomarkers, e.g. IL-8, IL-6, TNF-alpha, MMP9, significantly enhances accuracy over single markers. Machine learning, AI models, such as artificial neural networks, improve predictive performance. Adjustments, considering confounding factors like smoking, can further increase accuracy. Overall, salivary biomarkers are a rapidly advancing field with high potential, offering accurate and convenient diagnostics, especially when using multi-marker panels or AI techniques. Summary of salivary biomarkers and oral premalignant disorders and oral squamous cell carcinoma. 1. Epidermal growth factor receptor, EGFR, 18-fold increase in oral squamous cell carcinoma, 3-fold rise in oral submucose fibrosis. 2. MicroRNA 375, MIR375, reduced in oral premalignant disorders, reduced in cases with malignant transformation. 3. MicroRNA 142, MIR142, increased in OPMD. 4. Interleukin-1 alpha, IL-1 alpha. Interleukin-6 and interleukin-8, increase in progression to oral squamous cell carcinoma. 5. Interleukin-1 beta and interleukin-8, increase in progression to oral squamous cell carcinoma. 6. Alkaline phosphatase, increase in oral premalignant disorders. 7. Endothelin-1, increase in oral squamous cell carcinoma, followed by oral submucose fibrosis and oral leukoplakia. 8. Matrix metalloproteinase 9, MMM9, increase in oral premalignant disorders and oral squamous cell carcinoma, poorly differentiated. 9. Interleukin-6 and interleukin-8, increase in oral premalignant disorders and oral squamous cell carcinoma. 10. MicroRNA 320A, MIR320A, non-invasive predictive tool for dysplastic oral lichen planus. 11. Interleukin-1 beta and interleukin-8, potential for early detection of oral premalignant disorders and oral squamous cell carcinoma.
12. Interleukin-6, IL-6, proposed for further evaluation to assess clinical utility. 13. MicroRNA 184, 21, and 145, MIR184, 21, and 145. MIR21 and MIR184 increase in oral squamous cell carcinoma, and MIR145 is the lowest in oral squamous cell carcinoma. 14. MicroRNA 21 and MicroRNA 31. MIR-RNA 21 increases in oral premalignant disorders, OPMD, and MIR-RNA 31 increases during malignant transformation. 15. Interleukin-6, IL-6, and interleukin-8, IL-8,
useful biomarker for oral squamous cell carcinoma, but not influenced by oral lichen planus. 16. Interleukin-8, IL-8. IL-8 in saliva is a better predictor of oral squamous cell carcinoma, OSCC, than IL-8 in blood. 17. MicroRNA-24, miR-24, and microRNA-27b, miR-27b, increases in oral squamous cell carcinoma, OSCC. 18. Sialic acid, increases in oral squamous cell carcinoma, OSCC. 19. Interleukin-6, IL-6, increases in oral squamous cell carcinoma, OSCC. 20. MicroRNA-150b, miR-10b, microRNA-145, miR-145, microRNA-99b, miR-RNA-99b,
microRNA-708, miRNA-708, and microRNA-181c, miRNA-181c, used for monitoring oral squamous cell carcinoma, OSCC, precursor lesions, and early detection of disease progression. 21. Tumor necrosis factor alpha, TNF-alpha, and interleukin-6, IL-6, increase in oral squamous cell carcinoma, OSCC.
A paradigm shift. The promise of oral precancer. Oral precancerous lesions, characterized by subtle but meaningful cellular changes, are crucial to intercepting the trajectory toward full-blown malignancy. Assessing current paradigms. The need for change. Current investigative and clinical approaches to oral cancer often demonstrate significant gaps. Most studies emphasize treatment outcomes in established cancers, sidelining the nuances of precancerous manifestations. Towards aggressive intervention. Rethinking treatment paradigms. As we advocate for more aggressive treatments for oral precancer, it becomes essential to underline that these interventions could serve as a transformative strategy in the global battle against oral cancer. Salivary biomarkers demonstrate promising, often high, diagnostic accuracy for various conditions, such as cancer and periodontitis.
Meta-analyses report overall AUCs around 0.85 for cancer, with specific biomarkers achieving excellent sensitivity and specificity, over 90% for oral diseases, especially when combined with AI models. This makes saliva a valuable, non-invasive liquid biopsy for early detection and monitoring, though accuracy varies significantly by disease and biomarker.
Conclusions and future directions. 1. The focus of research in the cancer field should be shifted from full-stage cancer to the more promising area of precancer. 2. Cancer research should conclude with thoughts about how more aggressive treatments for precancer could be a successful approach for eradicating cancer. 3. Cancer research should be refocused by first explaining the faults of current investigative and clinical approaches to cancer, progressing through a biological explanation of precancer. This makes saliva a valuable, non-invasive liquid biopsy for early detection and monitoring, though accuracy varies significantly by disease and biomarker. Cancer. Meta-analyses indicate moderate to good accuracy, AUC approximately 85, and metabolites each provide different insights. Combination models, employing multiple biomarkers, e.g. IL-8, IL-6, TNF-alpha, MMP9, significantly enhances accuracy over single markers. Machine learning, AI models, such as artificial neural networks, improve predictive performance. Adjustments, considering confounding factors like smoking, can further increase accuracy. Overall, salivary biomarkers are a rapidly advancing field with high potential, offering accurate and convenient diagnostics, especially when using multi-marker panels or AI techniques.
Dear esteemed colleagues and guests, I sincerely appreciate your presence during my presentation on Saliva in Action, unraveling the link between salivary microbiomes and salivary biomarkers in oral premalignant disorders and oral cancer. Your engagement and interest in this vital subject are truly encouraging. Should any questions arise, or if you wish to explore the themes we've discussed further, please don't hesitate to reach out. You can contact me directly via the email address provided. Additionally, I invite you to explore my website, where you can find further information and resources related to this research. I am also excited to share that our book, Oral Submucous Fibrosis: An Introduction, has recently been published. It offers insights that complement our discussion. For more details, please visit our website. Thank you once again for your time and interest. Your support is invaluable to the advancement of our research. Warm regards, Dr. Subodh Nanavati.